Hello, and welcome to our listeners around the world. You're listening to JAMAevidence Rational Clinical Examination. Thanks for joining us. I'm your host, Dr. David Simel, JAMA Associate Editor and Professor Emeritus of Medicine at the Durham Veterans Affairs Medical Center in Duke University. In this podcast, we will be discussing childhood physical abuse. I'm joined today by Dr. Sonal Shah, who is an assistant professor of pediatrics at Harvard University, where she is an emergency physician in Boston Children's Hospital. Dr. Shah is an author of our Rational Clinical Exam article on childhood physical abuse, which appeared in the April 21st, 2025 edition of JAMA. Dr. Shah, thank you for joining us today.
Thanks so much for having me, Dr. Simel.
In your article, you described physical abuse as a subset of maltreatment, and that maltreatment also includes neglect, psychological abuse, or sexual abuse. Can you talk to us about the overall frequency of child abuse in the United States and why early detection matters?
Sure. So, according to the U.S. Department of Health and Human Services, over 550,000 children experienced maltreatment in the United States in 2022. And around 17% or 100,000 of those children suffered from physical abuse. In that same year, there were about 1,990 deaths from child maltreatment, and almost 840 were due to physical abuse. And that was either exclusively or in combination with any of those other forms of maltreatment that you mentioned. About half of those 840 deaths were in infants who were less than 12 months of age. So, the other thing that's important to remember is that these numbers are likely underestimates, as so many cases go either undetected or unreported.
Well, this is obviously a serious condition, and early detection sounds simple, but in concept only. The problem is that children have accidents, and there's an immediate challenge based on whether the child's preverbal or old enough that you can take a medical history. So let's set up a discussion here with, say, a child who may have a few bruises or a burn, or say a fracture. How do you go about getting the relevant history?
Yeah, I'm really grateful that you started with mentioning early detection. So, early detection is really a key component of child abuse prevention. We know that early detection is important because of the escalating nature of physical abuse. And just to highlight that with a little bit more data, children who experience recurrent abuse have a significantly higher mortality, almost 25%, than those who experience a single episode abuse, which is more around 10%. So when a child presents with an injury, really the initial goal is to figure out what happened and how. In so many ways, the clinical approach to an infant or a child with a possible abusive injury really doesn't differ significantly from routine pediatric or pediatric emergency care. So we start with getting the history from the caregivers, and that can occur either together or separately depending on the circumstances. But it's really important to not frequently interrupt that history. And so letting them tell the story from start to finish is very helpful. And then at the end, it can be helpful to ask clarifying questions and then have the caregivers expand on the activities and behaviors around the event. For preverbal kids, it can be helpful to know the details around their activities they were engaged in, feeding times, and their wellness leading up to the injury. Alternatively, if you don't know the time of the injury or there's a report that that's unknown, just trying to identify when the child was last known to be well and active would be important. The thing to understand is that this should all really happen in a non accusatory manner. So, even if physical abuse is suspected, it's important to keep in mind that the goal of that initial evaluation of the injured child is not to identify the person or persons responsible. It's not that first physician's responsibility to identify the perpetrator of abuse or extract every single detail of the abusive event. Really, the goal is to recognize the potential for abuse, obtain a thorough medical and event history, and then initiate the appropriate workup. If there are red flags that emerge, then referring the patient to involve specialists who are experts in completing that evaluation for abuse and investigation would be appropriate.
You mentioned ask clarifying questions. Can you give me an example of what you mean by that?
Yeah, clarifying questions can focus on details around when they saw the child last well, details around what happened specifically with the injury, like how did the child fall, for example, or what was the height that they fell from, what was the child like right after the injury, things like this to sort of hone in on the details surrounding the injury.
Sonal, when you're taking a history from a caregiver, do you take that history in the absence of the patient, or do you do that with the entire family together?
Often we start with the entire family together. If the injury is severe and the patient needs to be stabilized, we'll first focus on the child and treating the child and then obtain the history afterwards. And in that scenario, they would be separate from the child. But often we keep the family together. And then if concerns are raised, we will separate out the family to see. But by that time, there may be other people involved in obtaining the history, like a social worker, or if we get our child abuse experts involved, then they might separate out the families.
Well, recognizing that most injuries are accidental, what sort of things in the history would be reassuring?
Yeah, so that's right. Most of the injuries in children are accidental, particularly in toddlers and school age children. And their injuries are present in areas that we would expect them, such as the lower extremities. So, consistent history between caretakers and plausible mechanisms of injury, those would all be reassuring when taking that history.
Well, what sorts of things in the history would increase your concern for physical abuse?
Conflicting histories, vague or significant changes in the explanations if there are significant injuries, or really histories that are inconsistent with the child's developmental stage. And then finally, if there are just complete denials of obvious injuries or significant delays in seeking medical care, we would consider those to be concerning.
Give me an example of something that would be inconsistent with the child's development stage.
Sure. So if a child was not cruising or mobile in any way and they presented with a bruise on their abdomen, that would be concerning. Bruises in non mobile children in general are very concerning.
Your review highlights both sentinel injuries that suggest physical abuse that you might see as a generalist physician or an emergency physician, and findings associated with physical abuse among injured children who have been hospitalized. What exactly is a sentinel event?
I'm glad you've brought this up because it gets back to that concept of early detection, which, as we've already established, is so important. A sentinel injury is really a seemingly minor injury, but actually it precedes a more severe manifestation of abuse. And so sentinel injuries are important to identify because of their association with future inflicted physical abuse. It's especially true for infants and toddlers who are really at the highest risk of life threatening and fatal injuries. Prior sentinel injuries are found in about 25% of abused infants and one-third of children with abusive head trauma.
Well, you highlighted a few of those sentinel injuries, and I'd like you to go over them for me. The ones you highlighted were head injury, oral injury, fractures, and bruises. So let's go through these one by one and let us know what we should be looking for.
Yeah, if we could start with bruising, because bruises are the most common and readily visible injuries due to physical abuse, but they're the ones that are most often missed. And just to sort of drive that home, bruises are missed as a sentinel injury in almost half of all fatal and near fatal abusive injuries. And so we already sort of covered that preschool and school age kids are very active and sustain many bruises. And so not all bruises are suspicious of abuse. There are a few specific considerations, and It's just important to know that the patterns of overall bruising between abused and non-abused children are different. So there are 5 different categories of bruises that I thought would be helpful to talk about. There's bruising in the non-mobile infant. There's an adage in the child abuse literature that those who cruise rarely bruise. And so any bruise really in a non-mobile infant should be thought of as a potential sentinel injury. And then there are locations of bruises that are suggestive of abuse, and those can be the torso, the ear, the neck, cheeks, trunks, buttocks, and thighs. There's pattern bruising, which can have an imprint, like a handprint or a loop mark from an inflicted injury. Another one is subconjunctival hemorrhages. So, spontaneous subconjunctival hemorrhages in infants is very rare if they don't have prolonged coughing, vomiting, or a history of birth trauma. So, in a thriving infant, an unexplained subconjunctival hemorrhage can really be a marker of increased intrathoracic pressure from compression or choking forces. And then, just the final 5th injury I wanted to mention was an intraoral injury. And that can be resulting from a forcibly inserting an object like a pacifier or a bottle into an infant's mouth. Now, there is a great way to remember many of these sentinel injuries through a mnemonic developed by one of my co-authors, Mary Clyde Pierce. And that's this mnemonic called the 10-4 Faces P. So it's supposed to help one remember bruises concerning for abuse in children who are less than 4 years of age. So the 10 is the torso, the ear, and the neck. The 4 represents any bruise in a child less than 4 months of age. And the faces is the frenula, angle of the jaw, cheeks, eyelids, and subconjunctiva. And then finally, the P is to indicate pattern bruising. In our study, we were able to identify oral injury, subconjunctival hemorrhage, patterned neck and buttock bruising as highly suggestive of abuse.
What type of oral injuries are you talking about?
The main oral injuries that have been studied are frenulum tears or frenulum lacerations or bruising, intraoral bruising around the frenula, and that often results from sort of forcibly feeding an infant.
And what about fractures as a sentinel event? Children break bones.
Yeah, that's exactly right. And so the other category of sentinel events is fractures. So in terms of sentinel injury, rig fractures and classic metaphyseal lesions are strongly associated with abuse. But really, any fracture can be concerning in a non-mobile infant because they don't really generate the force, enough force to fracture their own bones. Most of the data regarding fractures in our study was derived from skeletal surveys in children with head injury, burns, or kids who were already undergoing an evaluation with child abuse. So, in that scenario where these kids were undergoing skeletal surveys, which are often ordered by child abuse experts, we found a strong correlation between fractures on skeletal survey, either single fractures or multiple fractures, and child abuse.
Well, you circle back to head injury, and I'd like to use that as an opportunity to talk about retinal hemorrhage, which your study also discussed. How do you go about detecting a retinal hemorrhage? Why do they occur, and what's their significance?
Yeah, our study really did affirm the idea that retinal hemorrhage is strongly associated with child abuse. The best way to identify retinal hemorrhage is to have a fundoscopic examination by an ophthalmologist, a pediatric ophthalmologist. They result from the sort of sheer forces of violently shaking a baby or injuring a baby. And so they are highly correlated with abuse. However, it's important to note that the absence of retinal hemorrhage does not indicate an absence of abuse.
It sounds like all physicians need to have a plan in place for their office or emergency department if they're seeing children, for getting child abuse experts involved in care when it's indicated. But that act alone can be scary because while you want to protect the child and not miss a true case of abuse, there are also real consequences to raising concerns about abuse, even if it proves not to be true. So, how does the clinician bridge that step to getting a child abuse expert involved?
I think it's helpful to frame the referral to a child abuse expert as a subspecialty consultation. Child abuse experts undergo extensive training, so it's 3 years of fellowship in child abuse after completion of 3 years of a pediatrics residency. And this gives them the expertise to assist with the determination of abuse. So once a potential for abuse has been identified in a child, it's reasonable to then seek expert consultation for guidance.
Well, I think it's important for generalists to understand what happens after their referral. So, how is it ultimately determined that a child has been the victim of physical abuse?
After a child is referred to a child abuse specialist, and that can happen either as an initial visitation in the emergency department or as an outpatient follow up if the pediatrician has arranged it, there's an extensive evaluation that occurs. Child abuse evaluations are structured, they're evidence based, and they're multidisciplinary. And that's to ensure a non biased and thorough evaluation is performed as the stakes are so high. The child abuse expert usually collaborates with a team that involves social work, child protective services, law enforcement, and legal teams. And so usually the child abuse expert starts with a detailed history and exam and then obtains any ancillary diagnostic testing that they deem is indicated. And that can be a skeletal survey, CT, MRI. It can also include an ophthalmologic exam or sometimes laboratory testing. So then all of this gathered data is reviewed by the multidisciplinary team who also share their own evaluations because they may have had their own interactions with the patient or the family. And then finally, in a collaborative effort, an integrated, comprehensive medical report and expert opinion is offered. And one of the important things to remember is that the role of the child abuse expert is to offer that expert evaluation on the likelihood of abuse, not to make legal conclusions.
Are there any other issues about screening and diagnosis of child physical abuse that you'd like to share with our listeners?
Yeah. What I really want to communicate is that the decisions of abuse carry some of the highest stakes in pediatrics. And so the data in our study isn't meant to be used to calculate a simple post test probability of abuse, especially since in reality, the outcome is binary. The kids are either abused or they're not abused. And so, because of this, our data should be used in a greater clinical context. There's no one finding that's diagnostic of abuse. So instead, our study is meant to highlight findings that are suggestive of abuse and warrant further investigation. The data can also be used to assist with broad bands of abuse concern. For example, concluding that simple skull fractures are relatively nonspecific when compared to something like rib fractures. And then finally, we can use this population based data to identify outliers in outcome from accidental injuries. This study is meant to help inform conclusions and conversations, but really just must be considered alongside several other factors when making a determination for abuse.
Well, I really appreciate you putting the findings from your study in that perspective because it really isn't just a mathematical equation to figure out whether or not a child has been abused or not based on the sensitivity or specificity of findings. It requires the whole picture and a team of experts looking at the entire breadth of data. Well, I am Dr. David Simel, and I've been speaking with Dr. Sonal Shah about childhood physical abuse. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.